Good evening, doctors. My name is Rahul Desai, and on behalf of FDC and Med Talks, I hereby welcome you all to today's live module of Diabetes Essentials, brought to you by Enerzal Zero and in memory of Dr. KK Agarwal, sir. Dear viewers, this is a social initiative altogether from Enerzal Zero with Dr. Sanjay Kalra, sir. Dear viewers, we are into new session of drug treatment modalities, and we are receiving huge response for all these sessions till now. The number of viewers attending as well as participating in the quiz are getting higher and higher, and this imbibes the importance of such sessions required for the viewers. The class of drug treatment today, which Sir will take us through, was approved in the year 2006. And as usual, before I hand over the platform to Sir to take us through today's topic, let me have the opportunity of announcing the winner's name of last episode's quiz. And the winners are Dr. Adi Narayana Potti from Andhra Pradesh. From Gujarat, we have Dr. C.F. Shah, Dr. Jitendra Kumar Shah. From Jammu and Kashmir, Dr. Mohammad Ashraf Nanda. From MP, Dr. Deepak Paradkar. From Delhi, we have Dr. Sumita Sharma, Dr. Bimla Kapoor, Dr. Major Prachi Garg, Dr. Ashwini Malhotra, Dr. G.S. Batra, Dr. Shubhlata Chatwal, Dr. N. Verma, Dr. P.C. Paji Pahwa, Dr. Manu Sharma, Dr. Surendra Chadda. From Haryana, we have Dr. I.C. Garg, Dr. Sukhdev Kumar, Dr. Manish Kumar Jain, Dr. Parmod Gupta. Then from Jharkhand, we have Dr. Gautam Datta, Dr. S.S. Rana. From Odisha, Dr. Gangadhar Rath. From Punjab, we have Dr. Sanjeev Puri, Dr. Namrata Puri. Next. From Karnataka, we have Dr. Ravindranath Katta, Dr. Achit Kumar Hegde, Dr. Basavraj, Dr. Ravi Bhatt, Dr. Ramesh Hegde. From Maharashtra, we have a bigger chunk of participants from Dr. Girish Gesota, Dr. Hitesh Vora, Dr. Bharat Picha, Dr. Damodar Jeswani, Dr. Sanjay Kanoje, Dr. DG Parmar, Dr. Saroj Narang, Dr. Pratap Parkar, Dr. Vidyulata Doshi, Dr. Jagdish Shah, Dr. Farid Kimani, Dr. Somnath Suryavanshi, Dr. Rajeshwari Sukku, Dr. Ritesh Khanna, Dr. Bhavini Gala, Dr. Neelam Mehta, Dr. Lalita Bhatt, Dr. Hutokshi Zaroliwala, Dr. Mansi Narurkar, Dr. Jayshree Avlekar, Dr. Sachin Gujarati, Dr. Nayana Shet, Dr. Posanlal Baisen, Dr. Pradeep Gavit, Dr. Kulbhushan Tandon, Dr. Anupam and Dr. Suman Agarwal, Dr. Supan Tuse, Dr. Sharad Jatakia, Dr. Virendra Jerurkar, Dr. Seema Shah, Dr. Shashikant Chende, Dr. Manju Vasudev, Dr. Pramod Umarji, Dr. Dharmika Tandon, Dr. Hitesh Harsha, Dr. Salahuddin K. Raza, Dr. Sanjeev Desai, Dr. Anand Purandre, Dr. Jayant Maru. Then from West Bengal, we have Dr. Shantanu Kumar Bhattacharya, Dr. Ashutosh Das, Dr. Dheeraj Kumar Haldar. From Rajasthan, we have Dr. M.R. Chipa. And finally, from Uttar Pradesh, we have Dr. Irfanullah, Dr. A.K. Sarkar, Dr. Sanjay Mehrotra, Dr. Krishna Bahadur, Dr. Surjit Kalsi, Dr. Pallavi Rai, Dr. Anil Upadhyay, Dr. A.S. Khanna, Dr. Ashwini Kumar, Dr. Devrat Rai, Dr. Suresh Kushwaha, Dr. Soeb Ali, Dr. Arun Kumar Garg. So congratulations to all those winners out over here. And with this, I hand over the platform to Sanjay Kalra, sir. Over to you, sir.
Thank you, Rahul, and warm greetings to everybody. We've been speaking for the past couple of weeks, for the past almost 2 months now. We've been speaking about various aspects of drug therapy in diabetes care. Today will be our last topic regarding non-insulin therapy. I hope my slide is visible. Rahul, is it visible right now?
Yes, sir, visible.
Yeah. We'll talk today about incretin-based therapy. We'll talk about DPP4 inhibitors and GLP-1 receptor agonists. Over the past few weeks, we've been taking one class of drugs at a time. Let's put things in perspective now. As a physician, we have so many drugs to choose from, so many drug classes to choose from that sometimes it becomes confusing. Let's compare diabetes therapy with chess. We've already spoken about this in the past. When you play chess, You have 16 chessmen with you, chess pieces. But with those 16 pieces, you can have multiple, you can have infinite permutations and combinations. The same is true in diabetes care. You have about 16 chessmen. Let's just take an example, just as a figure of speech. With these 16 chessmen, you can play whatever way you want. Sometimes a grandmaster of chess may be offensive. At other times, he may play a defensive game. At other times, it may be in between. But no two games of chess are the same, ever. Similarly, no two patients of diabetes are the same. But how do we make sense out of this complication then, out of this jumbled ecosystem that we find ourselves in? We do what we call a metabolic triage. Triage means dividing into three. So in our clinic, we have patients who are maladaptive anabolic. These are patients who are overweight or obese. They have high blood pressure, dyslipidemia. There is predominant insulin resistance. In general, they are the phenotype of metabolic syndrome. On the other end of the spectrum, there will be people with predominant catabolism. They will be thin-built, cachexic, marasmic, with osmotic symptoms, symptoms of diabetes, symptoms of acute complications of diabetes. Maybe exocrine dysfunction also. They might have pancreatic diabetes. The pathophysiology is predominantly insulin deficiency. They may have stigmata of other autoimmune diseases. So, for example, you might find vitiligo, arthritis, thyromegaly, a goiter, a skin rash, a malar rash suggestive of autoimmune disease. Once we have done this classification, we will also see that there are some patients who are eubolic, eubolic. Of course, they have dysglycemia, so that way they are not eubolic, but otherwise they are normal, lean people, not too overweight or obese, not too thin, not catabolic, not anabolic. They are normal kind of people with diabetes. Depending upon where you work in the country, you will find different percentages. For me, in my OPD, I guess 50 to 60% of all patients are maladaptive anabolic. Maybe 30% are eubolic and 10% to 20% are predominant catabolic. The predominant catabolic will also include pancreatic diabetes and type 1 diabetes. There will be some people who, from far off, they look maladaptive anabolic. Maybe somebody is on long-term corticosteroid therapy. Someone with portal hypertension. Somebody with sarcopenic obesity. The person is obese, but the muscle strength is not there. There is hardly any muscle over the upper limbs or lower limbs. From far off, they will appear maladaptive anabolic, but actually inside they are catabolic. We should be aware of this. Once you have done this triage, and you don't need too many investigations, you just have to look at the patient, speak with the patient, then you decide your therapy. For a catabolic patient, the drug of choice is insulin. Over the next 2 weeks, we will talk about insulin therapy, its regimens, its preparations, its delivery devices. If, however, the patient is anabolic, then apart from high-dose metformin, our choice would be GLP-1 receptor analogs and SGLT2 inhibitors. If the patient is eubolic, you can choose whatever you want, a sulfonylurea, a DPP4 inhibitor, alpha-glucosidase inhibitor, whatever suits you, whatever suits the patient. With this triage in mind, let's now first talk about DPP4 inhibitors. We have 6 drugs available to us in the country. Out of this, linagliptin, sitagliptin, and saxagliptin are supported by cardiovascular outcome trials. Vildagliptin is supported by good quality cardiovascular data, though not a definitive CVOT. Teneligliptin and evogliptin are not supported by robust data. How do these DPP4 inhibitors act? Basically, it's the incretin pathway. Incretin means intestinal secretion of insulin. IN, intestinal secretion, CRET, of insulin, INS or IN. Basically, when we eat food, when we eat carbohydrates or glucose, it goes into the GIT. In the GIT, various cells are stimulated, K cells and L cells. These secrete hormones known as GLP-1 and GIP. These go and act upon the beta cell in the pancreas, and they make the beta cell secrete insulin. So they are indirect secretagogues. So we eat carbohydrate, it stimulates the intestine. Intestine secretes intestinal hormones, GLP-1 and GIP, these are the incretins. They go and increase beta cell secretion of insulin. But this will happen only when there is food in the GIT. If there is no food in the GIT, the incretins will not work. So therefore, hypoglycemia cannot occur. This is the this is the major mechanism of action. But apart from that, GLP-1 also acts upon the alpha cell, and it reduces release of glucagon. So it reduces glucagon release while at the same time increasing insulin release. And all this put together leads to improvement in glucose levels. There is reduced secretion of glucose from the kidney, from the liver, and also increased uptake of glucose into the adipose tissue and skeletal muscle. This will not happen if intravenous glucose is given. If you give IV glucose, then there is no jump in insulin secretion. It's not as much as would have happened if oral glucose was taken. So that's why it's called incretin effect. What do DPP4 inhibitors do? When the body secretes GLP-1, GLP-1 circulates in the body. GLP-1 is broken down by an enzyme called DPP4, dipeptidyl peptidase 4. DPP4 inhibitors inhibit the activity of DPP4. So therefore, the enzyme doesn't work. It is not able to break down GLP-1. And then GLP-1 keeps on circulating in the body. So you have endogenous GLP-1, which keeps on stimulating the beta cell as and when required. There are many DPP4 enzymes. There are many DPP enzymes, DPP1 through 9. And the newer DPP4 inhibitors that we have more selectivity for DPP4. So they don't have any side effects or they don't have any collateral damage. Apart from what we explained just now, there is also an impact of DPP4 on of soluble DPP4, and there's an impact of DPP4 inhibition on soluble DPP4 as well as membrane anchored DPP4. So apart from what we have mentioned, there is also data to show that DPP4 inhibitors are anti-inflammatory. They act in diabetes, also in obesity. With DPP4 inhibitors, you are able to get good HbA1c reduction, good glucose reduction, both fasting and postprandial. The data shows that it is equally efficacious and non-inferior as compared to other OADs. But we do have a question from the house. So this is what the data says. And if the HbA1c is high, to begin with, you will get more HbA1c reduction. If the HbA1c is less, to begin with, you will get less HbA1c reduction. In my practice, I do find that sulfonylureas are more effective than gliptins. They are able to control glucose better, but there is a high risk of hypoglycemia as well. If you have a patient who is soft, where you are worried more about hypoglycemia, then a gliptin would be a better choice. If you are worried more about efficacy, you want to bring the glucose down swiftly. Patient is waiting for a surgery. So the patient is symptomatic, the patient is requiring swift control, the patient is waiting for a surgery, then sulfonylureas would be a better choice. Hypoglycemia is minimal with gliptins, and they are weight neutral as well. So if you want safety, then gliptins are the way to go. And overall, all the gliptins are equally effective. The only difference that you get is in terms of pharmacokinetics. So if you have a patient with renal impairment, then linagliptin would be the safest. You can also use sitagliptin, saxagliptin, and vildagliptin, but you will have to change the dose. So if you are able to monitor EGFR regularly, then we can also use sita, saxa, or vildagliptin in a patient with CKD. If you are not able to monitor, then linagliptin would be the best choice. The advantage of using a DPP4 inhibitor in practice is that it is easy to use. You don't have to do too many tests. You don't have to screen. You don't have to monitor. And it's event-free. There will be no issues. Patient will not come and complain of anything. And it's error-free. The chances of making mistakes are minimal with this class of drugs. There can be increased risk of nasopharyngitis or headache or sometimes UTI or pancreatitis, but this is very, very rare in practice. So you usually don't have to worry about these. From a CV point of view, they are safe. They are not beneficial, but they are safe from a cardiovascular point of view. From a renal point of view, they are safe as well as beneficial. So we get the strongest data for linagliptin. It is safe and beneficial from a renovascular perspective. Saxagliptin is one drug. Saxagliptin is not used often in the country, where there is an increased risk of hospitalization due to heart failure. So that is a drug which you should avoid if there is an increased risk of heart failure in a patient. When can we use DPP4 inhibitors? Very rarely. You can use as first line if the A1C is low and patient is not able to tolerate metformin, or if metformin is contraindicated. The American guidelines recommend it for use in pre-diabetes as well because of its safety and lack of hypoglycemia. If patient is not controlled on metformin or any other drug, very happily we can add a gliptin. And also if the patient has an A1C of 8.5 or more, you can give it as part of triple oral therapy. Metformin, gliptin or DPP4 inhibitor, and a third drug, maybe a sulfonylurea or maybe pioglitazone. Do remember that DPP4 inhibitors and GLP-1RA cannot be given together. Both are incretin-based therapy. The ADA now recommends a hit early, hit hard approach. In Bengali, Age Maro, Jore Maro. In Punjabi and in Haryanvi, Cheti Maro, Zor Di Maro. So can we have in the comment box, what is hit early, hit hard in your language? It would be nice to learn all the Indian languages. The ADA recommends that we should start combination therapy early, especially if the A1C is above 8.5, because if you give intensive control early on, you are able to get what is called a metabolic memory or a glycemic legacy, and you are able to reduce long-term complications as well. So when we prescribe therapy to our patient, maybe metformin plus vildagliptin, as was studied in the Verify trial, we can tell our patient that we are trying to manage not only your today, but your tomorrow as well. And the tomorrow and day after tomorrow, all will be benefited from a health point of view if we are able to give you good control today. We have spoken about DPP4 inhibitors. Let's move now to GLP-1RA, glucagon-like peptide 1 receptor analogs or agonists. These are an injectable form of incretin-based therapy, but there is a caveat: an oral drug will be available in India later this year. These also act the same way that DPP4 inhibitors act. Instead of endogenous GLP-1, which is secreted from the intestine, these are exogenous or administered from outside GLP-1-like agonists. They go into the circulation, reach the beta cell of the pancreas, and then join to the beta GLP-1 receptor, which in turn closes the potassium channels and stimulates release of pre-secreted insulin. So DPP4 inhibitors were using endogenous GLP-1. GLP-1RA are using exogenous GLP-1. And this is called pharmacological concentration. With DPP4 inhibitor, we had physiological concentration. If you remember, with DPP4 inhibitors, we said that the predominant mechanism of action is reduction in insulin. Increase in insulin, but also reduction in glucagon. Let's look at this again. And we call this the fulcrum, the islet-centric fulcrum hypothesis. When you give GLP-1RA, it reduces alpha cell activity, reduces glucagon. Because there is less counter-regulatory effect, the beta cell also relaxes. The beta cell realizes there is no glucagon around me. I don't need to work so hard. I don't need to counteract glucagon. So it will reduce working. And it will work only when required, only when food is taken. The beta cell relaxes, and then the alpha cell gets the message, there is no insulin to fight, there is no beta cell to fight, why should I work so much? So it reduces its glucagon even more. And this way you get an islet de-stress, DE stress. The islet of Langerhans de-stresses and comes back to near normal, where alpha cell will produce glucagon only as and when required, beta cell will produce insulin only as and when required. And this is the basic crux of mechanism of action of GLP-1R. With GLP-1, of course, we have glucose-lowering benefits. They are very effective in lowering glucose, but the extra glycemic benefits are important. And liraglutide, dulaglutide, and semaglutide, these are the 3 drugs available in the country. They are known to be not only CV safe, cardiovascular safe, but CV beneficial as well. Liraglutide in the LEADER study has been shown to reduce the risk of cardiovascular events and reduce the risk of cardiovascular mortality. It actually modifies the progression of atherosclerotic cardiovascular disease. The drugs that we can use currently in India are subcutaneous liraglutide. Begin with 0.6 milligram once a day, injectable. Give for a week or 10 days, and then uptitrate to 1.2 or to 1.8 milligram. The side effect will be nausea, vomiting, very transient, very mild. That is why we uptitrate slowly to prevent GI symptoms. If patient has GI symptoms for the first 4 or 5 days, you can always add maybe proton pump inhibitor an anti-emetic drug, or give folk remedies like maybe some kind of a candy or a hajmola, which will help the patient. Dulaglutide is available as weekly injection. Begin with 0.5 milligram per week and then go up to 1.5 milligram. Soon, a few months from now, oral GLP-1RA will be available in our country. You have to give 3 milligram initially, then uptitrate it to 7 milligram per day, to be taken first thing in the morning upon waking up with a glass of water. And if 7 milligram doesn't suffice, you always have a 14 milligram tablet to use. So these are the GLP-1RAs which are available. Because DPP4 inhibitor and GLP-1RA both act through the incretin mechanism, they should not be given together. With DPP4 inhibitors, we said that there is hardly any side effect, and that is true. With GLP-1RA, you do have to be careful. So we spoke of GI disorders. If you counsel your patient properly and empower the patient on how to manage AEs, life is usually fine. So start low and go slow. We spoke of dose titration. You can use ondansetron and PPIs. You might want to use lactobacilli containing probiotics, and tell the patient to modify diet by reducing fats, spices, or flavors in the food. Realistic goal setting is also important. The patient should be able to understand how much of glucose control and how much of weight control there will be with liraglutide or dulaglutide. And also, these drugs are not going to act in isolation. We have to continue our efforts in lifestyle modification. If HbA1c target is not achieved with either DPP4 inhibitor or GLP-1RA, we just add another drug. Don't wait more than 3 months. And like we said, don't add them to each other, but you can add any other class of drugs. And the best HbA1c reduction that you will get, apart from insulin, is with GLP-1RA. There is a South Asian guidance, and many of you in webinars, you would have seen guidance from America, from Europe. But this is a South Asian work task force, which published its findings before findings came from America or Europe. And this is what we say. GLP-1RA must be given if there is a compelling indication or need to reduce weight, reduce appetite, or reduce weight gain. If there is a need to reduce the risk of hypoglycemia, and if there is a need to reduce CV risk and improve CV outcomes. These are the compelling indications for GLP-1RA. However, if your patient has type 1 diabetes, DKA, pancreatitis, medullary thyroid carcinoma or MEN2, multiple endocrine neoplasia 2, or is planning pregnancy, this may not be a good drug to use. Many times we do use it in women who are planning pregnancy because they are really overweight and they are diabetic. So we tell them, let's postpone pregnancy by 6 months or a year because the long-term outcomes will be better. Let's first give you liraglutide, reduce weight, and then once you lost maybe 5% of your weight or 10% of your weight, you put an endpoint also to that. Then we will stop liraglutide, start insulin, and then you can plan pregnancy. If patient has hepatic disease, renal disease, or diabetic gastroparesis, then be a bit careful and think before prescribing. You can also add GLP-1RA to patients on insulin, people who have high dose of insulin requirement, people who are obese or increasing weight on insulin, or if you want to reduce the number of injections, then liraglutide will help reduce insulin requirement and will reduce weight gain. Let's go back to our questions now, the ones that we asked last week. And like you've seen, we are very grateful. The participation has gone up. The number of people who win prizes has gone up. And it's fun. It's nice to grow together, to learn together. A common side of glitazones was water retention and weight gain. This was the answer to last week's question. And another question was, hypertonic solution means that the solution has a higher osmolality than plasma. Today, we've spoken about DPP4 inhibitors and GLP-1RA. We've spoken about other drugs in the past. Let's look at our first question for this week. Most patients with type 2 diabetes are overweight or obese. We call it diabesity. Which of the following combinations is best for not only glucose control, but also weight loss? Is it glyclazide and glargine, or liraglutide and dapagliflozin, or maybe metformin and acarbose, metformin and rosiglitazone, or metformin and sitagliptin? So which combination will help us reduce weight the most? sulfonylurea and insulin, or GLP-1RA and SGLT2 inhibitor, or metformin and AGI, metformin and glitazone, metformin and DPP4 inhibitor. Our second question is, again, you remember Enerzal 0. Miss Y is having a low output of urine. What will the doctor prescribe? A hypotonic solution, a saline injection, hypertonic solution, or isotonic solution? So with less urine output, what do we give? Hypotonic, hypertonic, or isotonic solution? Do remember it is summertime, and many of our patients suffer from heat cramps and heat exhaustion. And touch wood, they shouldn't go into heat stroke. To prevent all these and to manage all these, one of the best medicines or one of the best nutraceuticals you can use is, again, Enerzal 0. Perfectly crafted to help manage the heat cramps and heat exhaustion that our patients face so much. We've had a lot of good questions today. Let me share those questions and try to answer them. So, Dr. Amar Singh Yadav asks, what are the side effects of DPP4 inhibitors? Very rarely you will see them. If you're giving high dose of sitagliptin or saxagliptin, you might worsen renal health. Saxagliptin may cause heart failure in people who are predisposed to that. And very, very rarely you will get pancreatitis. But I myself have not seen any case of pancreatitis with DPP4 inhibitors. Another question is, can DPP4 inhibitor be given safely to a patient who has a past history of pancreatitis? This is from Dr. Irfanullah. So Dr. Irfanullah, thanks a lot for this question. Look at the patient. If the patient has pancreatic diabetes, per se, pancreatic calcification, the gliptins will not be useful. Do not give them. If patient had pancreatitis in the past, and you can find a cause for that, maybe gallstones, maybe alcohol, maybe high triglycerides, that cause has been corrected now. Also, you really feel that you need to give DPP4 inhibitor only, then we can always give another trial, mention that you are giving a trial, and ask the patient to report back to you immediately if there is pain abdomen. Dr. Hitesh Vora has sent a very nice point. Thank you, Daksa, for hit early, hit hard. Todinak tabla, Todinak party. Thank you, Dr. Hitesh, for that. So I've learned some Gujarati as well. Dil le gaya Dr. Gujarat da. So we have this famous Punjabi song, Dil le gayi kudi Gujarat di. Aaj ka dil hamare Dr. Hitesh Vora le gaye. We have more questions also. Teneligliptin, Dr. Vishnu Mulchandani says, can we give 40 milligram OD? Yes, that is the maximum. But do be aware that you should always look for conduction defects like QTC prolongation if you are giving high dose of teneligliptin. And sometimes when added antibiotics or antifungals are given, then drug-drug interactions can occur. Dr. Major Prachi, there were only 4 options in question 1 today, and many answers that we are getting. So Dr. Vinita Shetty says, is it advisable to reduce doses as soon as the HbA1c reduces or comes down? Yeah, so this is a tough question. Depends upon the patient. So how we tell the patient is, we are going to climb a mountain and we are going to come down. If there is sudden change in HbA1c, it is coming down from maybe 12 to 9, 9 to 7. It's coming down fast. Either you begin calling the patient back more frequently, or you reduce the intensity of your dosing. If, however, the HbA1c is going down slowly, 8 to 7.5, 7.5 to 7.3, and now 6.9, going very slowly, then you continue the same dosage. Dr. Manu says, give us an example of adding GLP-1. Let me try that, Manu, and thank you for this question. Manu, सवाल बड़े मुश्किल पूछता है. That is, so let's try. So how will we add GLP-1? First line, patient came to me with maybe newly diagnosed diabetes, HbA1c 7.8. He is 110 kg. So I'll tell him, you've just come to us with diabetes. You've not taken any medication. We've not hit your beta cells so far. It is possible that you may go into remission. There is a chance of going into diabetes remission. We follow the ABCDE formula. A, if the age of the patient is less, young gentleman or lady. B, if the body mass index is more, patient is obese. C, if the C peptide is more, that means pancreatic function is preserved. So I don't do a C peptide It's just a way of reminding us. There's no insulin deficiency in the patient. It's not type 1. D, if the, now I forgot what D was. A is age, B is body mass index, C is C peptide, and D is duration of diabetes. If the patient has come to us with a short history of diabetes and a short history of uncontrolled diabetes. E is for enthusiasm and energy of the patient. Is the patient willing to follow our therapy? If the ABCD are correct, then we'll say let's start lifestyle modification and liraglutide, 0.6 milligram once a day for a week, and then we go up to 1.2 milligram. The cost will also be more. 0.6 milligram will cost around 100-120 rupees per day. You have to buy one pen which contains 3 milligrams. You give this to the patient follows diet and exercise, and after some time you will actually find that the glucose level is coming down and the weight is also coming down. It won't act within one day, but within a week or 2 weeks you will get the results. Now, after 3 months, your patient is going to say, Doctor Sahab, this expensive medication, will I have to take it lifelong? So, when such a thing comes up, or even before that, you talk about endpoint. What is our endpoint going to be? Either we want to reduce 5% of weight, or we want to reduce 10% of weight, or we just want to change the trajectory of weight gain. My weight is going up and up and up. Every month I gain 2 kg. Let me stop the trajectory. Let me bring down the weight by 1 or 2 kg. And now my weight is not increasing. I can maintain it with lifestyle modification. So this is first style, Manu. Second is patient is on metformin and sulfonylurea or metformin and voglibose. Patient has got weight associated issues like he is overweight or is gaining weight or has too much of appetite. And patient says, I want to take something to reduce my weight. You think of giving SGLT2 inhibitors, but patient has frequent fungal infection, genital infection. So then you say, let's talk about GLP-1RA. Also, if you're giving dual therapy, maybe metformin plus sulfonylurea, and patient has got coronary artery disease or has multiple risk factors for coronary artery disease, then again, we'll add liraglutide to this. If you are giving it for CV benefit, you will reduce the sulfonylurea dose and add GLP-1RA. If you are giving it for glucose control as well, earlier the glucose control was not good, we will continue the previous doses and add GLP-1RA. That was second. Third is, Manu, if patient is on insulin, maybe basal, maybe premixed, maybe basal bolus, and you've reached 0.5 units per kg per day of insulin. You take a break and you say, is there something wrong? Am I doing something wrong? Is the patient doing something wrong? You can't find anything. You keep on increasing the dose, and now suddenly you've reached 1 unit per kg per day of insulin. Patient is weighing 80 kg and we are giving 84 units of insulin, and we are heading nowhere. Glucose level is not coming down. It means we are climbing the wrong coconut tree. We are treating insulin deficiency while actually the patient has got incretin deficiency or has got insulin resistance. So we are treating the wrong pathophysiology. So let us go diametrically opposite. Let us add liraglutide. Again, begin with 0.6 milligram. If glucose levels are normal, reduce the insulin by 20% right at the beginning. But if insulin levels are very high, then continue the same insulin, add GLP-1RA. Tell the patient 20-20 formula. Sir, I am confident that 20 days from now, your insulin dose will have reduced by 20%. And actually, it will happen. You will see that. In the third part, first we said that if insulin doses are very high, then you add GLP-1RA. Also, if patient is gaining weight on insulin, the insulin dose is not so high. You are giving total 40 units a day, but patient is gaining weight every week because of the over anabolic effect of insulin. Then we would want to add GLP-1RA. Also, if the patient has got atherosclerotic cardiovascular disease or multiple risk factors, you can add GLP-1. How will you motivate your patient? You have multiple risk factors: smoking, obesity, diabetes, family history. So see, in the blood vessels that you have, there is slime or dirt that is stuck to the blood vessels. It can be sugar, it can be tobacco, it can be cholesterol or triglycerides. We are trying to dissolve all that slime which is stuck to the blood vessels, to the inside of the blood vessels. We can do that by giving GLP-1RA. These modify atherosclerosis. If we are able to clean the insides of your blood vessels, it is equivalent to doing a medical stenting. you will not need a stent later on. So that is the way you talk about GLP-1 and its CV benefits. Dr. Suresh Patil says gliptin, vildagliptin, it can be given twice a day. 50 milligram BD is the ideal dose. Between teneligliptin and vildagliptin, Himanshu, more data on vildagliptin. And if you get genitourinary infection, Dr. Hitesh Vora asks, with SGLT2 inhibitors, like with DAPA, EMPA, or canagliflozin, it's good to use fluconazole. Topical therapy usually works better. So you can give a topical antifungal. You can also give oral. The oral one, fluconazole, is what I use. If it doesn't work, you can use terbinafine, or you can use itraconazole. One folk therapy which may help many of your patients, you can ask them to use cinnamon. The Hindi word is dalchini. So you get the best quality cinnamon, ground it into powder, and you can apply it on the tip of the penis with the water, or with coconut oil, or with ghee, and it helps many patients. Dr. Vishnu, I apologize. I saw this just now. The fonts are very small. Next time I will take care. I apologize for that. And Dr. Rajender, we had already answered that DPP4 inhibitors are as effective as sulfonylurea, but if you want swift control, very fast control, then sulfonylurea may be a better drug of choice. Do remember to keep the needs of your patient at the center of all your decision making. And thanks to everybody who has logged in with us. Mr. Dr. Harish Khatri has a question. What is the cost of the whole course? I will request Mr. Anand from FDC to answer that question, please.
Sir, I think with looking into the number of questions, I myself has typed you that it won't be possible to take all the questions today, because now with GLP-1 RA and DPP4 coming in picture, and not many doctors in India being given uh, courses or advanced training or CMEs. And even if they are, then they are molecule specific, company specific, biased views coming in. This is a platform where we keep on saying that access to diabetes care through Dr. Sanjay Kalra to millions of doctors practicing in India and have the patients to treat diabetes. So this is a non-bias. And I also want to tell to all my viewers that today the slides which we have seen today, in the references you could see Dr. Sanjay Kalra, Dr. A.K. Das, where the researcher and those people have published the paper. So this is coming from the original researcher itself. That too, hats off to Dr. Sanjay Kalra that he's sharing his own work to all of us. And to end this session, that I would request sir, and to all the viewers that Kalra sir will, I think, need to work out that how he will design DPP4 and GLP-1 RA related questions and insulin resistance, insulin sensitivity, over insulin, non insulin, obesity, all put together. I think we need, sir, you have got a task. You have got a task.
Yeah, I just realized there are other questions
You have
which I
got a
had
task.
missed. So, Dr. Anshul Singhai from Precision Diabetes Care says, which is the best insulin sensitizer? Metformin, pioglitazone, or GLP-1 RA? Actually, a combination of the three would be the best, Anshul. But if you had to choose one, it would be metformin that we would choose. But ideally, the answer is a combination of all three. As monotherapy, GLP-1 will not be able to replace metformin. First of all, injectable versus oral. Of course, oral semaglutide will come. Second, cost. Metformin is one of the most economical. GLP-1R is exactly on the other opposite end of the spectrum. So I doubt if it will replace metformin. GLP-1, the limiting factor is the cost actually. If you're able to write it, do right if your patient can afford and can understand. If patient is not able to lose weight in spite of adequate doses of GLP-1 RA, then the options are you can add an SGLT2 inhibitor if patient has diabetes. This question is from Dr. Madan Sadani. You can also think of adding orlistat, or you can add medical nutrition therapy. High dose protein, 38% protein. Allow me to use a trade name. Vida Slim is what I use. And you can do a meal replacement. 1 or 2 meals can be replaced with high protein powder. And Anshul, usually I don't rule out retinopathy. It is done as routine part of testing. But we will not get a fundus done and wait for the fundus report to come before starting GLP-1. It is safe to use. HbA1c reduction effect you can see within 6 weeks as well. So I hope we have taken all the questions today, Mr.
So,
Anand,
sir,
and
what
thank
we
you
will
for
do
your
that, sir,
patience
we
as
are
well.
recording all the questions, and like we have decided earlier also that in few coming sessions where there will be less of substance and content, and then we can ask these questions again on the behalf of the doctors who have asked today, or it's not a limiting factor that Dr. Kalra will be with us only for 52 weeks. It can extend to 60, 70, 80, because that's the requirement of the country. So I think today, I think is the more or less it has completed, sir, and I thank you very much
No, we got
because
Sindhi also. If Anang, if Gujarati is there, how can Sindhi be far behind? So from Dr. Vishnu Mulchandani, Jaldi Hano Dado Jorsa Hado. Hit early, hit early.
so, sir, thank you today. I think it's more than and we will work again that how do we take these questions maybe in a session or as you progress, because these all matrices put together is need to be convincingly communicated to doctors for their own practice, and I think you are the one who is doing the best work with your own research and papers coming in picture. And this course is completely free. All the lectures are getting recorded at the link at from all people can watch it for free, and it can be circulated also. But you have to register, and you have to come every Saturday, every Sunday at 9 p.m. to see and ask questions to Dr. Sanjay Kalra on a regular basis. Thank you very much, sir. Good night. Jai Hind.
Jai Hind.